So this is a chart looking at the number of deaths diagnosed between 1979 and 2010. And back in 1979, we were getting around about 240 new diagnoses of penile cancer a year. And then if you fast forward to 2010, we're getting just over 400. So you're looking at a 70% increase in the numbers here. If we look at the age-standardized incidence rates in the UK compared to a European population, you can see back in 1993 it was 1.8, and then fast forward to now we've got 2.3, which is a 27% increase. So I think the data seems to be suggesting that penile cancer is increasing. Why is this? Well, I don't think it's down to one thing. I think it's probably multifactorial. One of the issues is that since the 1930s, circumcision rates have been reducing, and we know that there's an association between circumcision status and penile cancer. Further, this document here, which was released in 2002, Improving Outcomes in Urological Cancers, may also have a role in this. So maybe we are picking up, maybe there's more of a formalized structure for referral, and we're picking up these patients earlier and recognizing them. If we look at this graph here as well, again, age-standardized incidence rates in the UK, but split up into age subgroups, you can see that the largest or the biggest increase over this period of time has been in the 60 to 69-year-old group. That's been an increase of 70%. That's pretty impressive. So one wonders why this might be. Well, if we extrapolate this backwards from 2012, we're looking at the kind of people who are around in their 20s and around the post-war time, as well as the kind of 1960s. And since then, we've seen a proliferation of HPV. And we know that HPV subtypes 16 and 18 in particular are an increased risk of penile cancer. So that could be another explanation why. So what is this document? Well, for those of you who are unfamiliar, this was a document that was released in 2002. It was Improving Outcomes in Urological Cancers, and it was released by NICE. And the idea of this was really to kind of examine all urological cancers and see if we could redesign services a little bit. And in penile cancer, recognizing that it is a rare cancer and it was being dealt with in the district general hospitals, the idea was to focus them down into regional centers where you can get better expertise, hopefully do some research out of that and get some meaningful answers. And hopefully at the end of it, which is what it's all about, is improving a lot for these kind of group of patients. So it was stated that these centers should have a population of 4 million or more and more than 25 cases per year. So this is what it was like before it. And this was a study by Ritchie, who sent out part of BAUS questionnaire to all members. And between 1998 and 1999, that's 2 years, there were 90 centers who were dealing with penile cancer, 119 clinicians, and 243 penile cancers. Bear in mind, that's over 2 years, not 1 year. The most people would see, therefore, is around about 5. Most people were seeing 1 or 2 cancers a year. Fast forward to 2014, and this is what we have now. We've got 12 centres in the UK, around about 30 clinicians, and we've got 632 penile cancers. This was in 2014 based on the ONS data. So what does a modern penile cancer team look like? Well, it looks a little bit like this. This is ours from our peer review. We've got 4 consultant surgeons, we've got 2 clinical oncologists, 3 specialist histopathologists, 4 radiologists, 5 specialist nurses, and I admit they're shared with sarcoma and prostate cancer, an MDT coordinator, in fact 2 of them, but that's not it. We've got psycho-oncologists, pain specialists, and palliative care as well. So actually the service now has been transformed from one-man units to significant infrastructure for these patients. I suppose the question though is, has it actually made a difference? And this is the number of deaths per 100,000 over a period of time, from 1971 all the way to 2014. And you can see a gradual improvement over that period of time. And I've put in there a marker for 2002 where that document came out. You may just get a little bit of a perception that it may be kind of flatlining there a little bit, but that would be with the eye of the beholder, if that makes sense. If we look at the age-standardized relative survival in men diagnosed with penile cancer, this is a paper by Arya, you can see we've got 1-year survival and 5-year survival. And that's between 1971 and 2011, and there's been a general improvement. So the 5-year survival has gone from 61.4% to 70.2%, and the 1-year survival 76 to 88%. Why is this? Well, there's probably a number of factors. I think it's probably how we're managing things like groins. So whereas before people who had non-palpable disease were either managed more likely with surveillance, were now being managed with dynamic sentinel node biopsy. And so we know the data would suggest that those people who are left, managed by surveillance, then developing inguinal lymph nodes do worse. So I think dynamic sentinel node biopsy up front, diagnosing these people and treating them has really made that difference. If we kind of take a microscopic view as opposed to a macroscopic view, we can look, this is one unit, this is George's unit. This is looking between 1996 and 2000 versus 2001 and 2011. And again, you can see the difference. You're seeing 294 patients beforehand, centralisation 433. The 1 year survival, not really changing, a bit interesting, whereas the 5 year survival has made a significant change and gone from 77.4 to about 84.9, that's 12% roughly. Why is that? Well, the question you've got to ask yourself is, who are these patients that are dying within a year? And these are the guys with metastatic disease. And actually, very little in that sense has changed, in the sense of chemotherapy regimens. There have been phase 2 trials, small trials with small numbers in it, but nothing really has made a significant difference. Until recently, and then you can ask yourself a little bit about the kind of upcoming immune modulating medications as well, but no trials currently exist in that sense in the UK. So here I just wanted to contrast different management methods. So this was back in 1999, and if you have a little look, this is the staging across the top, and it runs from 0 to 4. It's slightly changed now, but essentially 0 is CIS, and 4 is, as you can see on the picture, nasty-looking disease. So if you look at 0 CIS, 73% were treated with penile sparing, okay, fair enough, but 27% were being dealt with traditionally, i.e. that means partial penectomy or total penectomy. For CIS, I don't think that's necessarily appropriate. And also 5% of those were getting lymph node dissections. And if you look at the grade 4 ones, 44%, these are the nasty ones, were being treated with penile sparing techniques. I'm not quite sure what was going on there. Maybe it's palliation, but it just doesn't seem to really make very much sense in that sense overall. If you compare as two pie charts, this is looking at that data, again, put into a pie chart as a proportion of operations, as it were. And then this is the right side, the 2016 is our data at the Christie's this year, looking at proportions. It's not that great way of comparing, but just gives a bit of an idea. You can see partial penectomy there at the bottom at 35% has now reduced to 17% at our institution. Glanzectomy is taking a bigger role, so the penile sparing. Total penectomy has pretty much disappeared in comparison. Lymph node dissection has taken a hit, so that's reduced, understandably, and as a result of that, dynamic sentinel node biopsy has come in and taken over. And then you've got biopsy and local excision. So the paradigm before centralisation was essentially oncology outcomes and a little bit of voiding function, and this is what people were left with. But things have changed. And some of that work has been done by people in the UK. So, for instance, Minas and Agwell, Hoffman, they've suggested that basically you can take closer margins, and that's allowed us to move towards that penile sparing paradigm. Also, the confidence to do penile sparing surgery and accept the fact that the recurrence rate is a little bit higher, comparing radical surgery is around about 5% and less versus penile sparing is around about 9%, has allowed us to do that. Looking at the Dinner-Dinner-Grat data has suggested actually if you get a recurrence, it doesn't affect your overall survival, hence we can go for penile sparing surgery. So this is the paradigm change, and if you look in 2017, this is a guy who's had glands resurfacing, looks pretty good in my opinion, but the oncological outcome is there still, but we're taking on board sexual function, cosmesis, psychological issues, and voiding functions as well. So this is a paper that I did at UCLH, and this is looking at glanzectomy. And again, here we're talking about recurrence, we're talking about functional outcomes, and as you can see, here's the glands being taken off, and eventually a graft being put on, and these guys end up with great functional outcomes. Recurrence rate a little bit higher than, as I said before, 9% in this series, but still we can accept that because we know it's not going to affect their overall survival. If we look at the groins now, the paradigm here has also changed. And whereas before we did radical inguinal lymph node dissections, which was a terribly morbid procedure, we've now moved through a series of steps. So if we look, there's modified inguinal lymph node dissection, which was proposed by Catalona, taking less lymph node tissue, but focusing on the areas where it's most likely to occur. And then we've now kind of moved on to the kind of where we are now, which is dynamic sentinel node biopsy, which is pretty much the gold standard for impalpable disease, and we must be very clear about that. What's on the horizon? Well, there's video endoscopic inguinal lymphadenectomy, or if you like to be shorter, it's VEILND. And then there's also imaging modalities, and certainly there is a trial at UCLH currently ongoing in that sense, looking at MRI PET, to see if we can actually avoid some surgery in some of these people. If we look at VEILND, now this is a study, I'm really impressed by these guys. These guys took on something that hasn't been done in the UK, and have really kind of pushed the envelope. And the idea of this is to try and replace radical lymphadenectomy with laparoscopic or keyhole surgery to reduce, hopefully, the complications. And that's a brave thing to do, I think, in this kind of climate. But you've got 42 patients here. They've compared, these are not randomized, these are just taken as they came. 35 had open inguinal lymph node dissection, 33 had essentially laparoscopic inguinal lymph node dissection. And here are the comparisons. 94 minutes for the operation in open versus 97 minutes in the VEIL. Lymph node count was higher in VEIL as well at 9.4, and there is data out there, just like in bladder cancer, that if you take more lymph nodes, you possibly are doing a better operation. Also, your length of stay is shorter, 2.5 versus 7.3, so it's making a difference in that sense, and no recurrences in either group. So this is where the crux of it comes in, is the complication rates. And you can clearly see between open inguinal lymph node dissection and the VEIL, or the laparoscopic lymph node dissection, the complications are significantly lower here. So you've got less wound complications, no prolonged drainage, no drainage of collections, debridement, there was one, compared to 28 or 23%, leg edema, again less. And the only thing that's kind of equivalent, or if you could argue slightly higher, but non-statistical, was the prolonged lymphocele. So where does this fit in? Where do we see this coming in now? Well, if we look at impalpable disease, the paradigm, as I said, is now dynamic sentinel node biopsy. And here we can see the comparisons of complications. And you can see quite clearly, if we look at the UK VEIL, the rates are very low, but dynamic sentinel node biopsy is lower and cheaper and quicker in that sense. I've been a little bit unfair here to VEIL, in all fairness, because what I've done is, you see, as I've combined the VEIL data from the UK and combined it with the Americans, they've let us down a little bit in this. This was a larger study. It was people who were training as well, so they weren't over their learning curve. And you can see the complications are a little bit higher than you would necessarily want. That's so lymphoceles 14, infection 23, compared to the standard inguinal lymph node dissection. Edema was higher as well, but the necrosis was less. And you could expect that because you're making smaller wounds. So I'm not quite convinced necessarily for non-palpable disease, but the role for palpable disease could be there. So if you look in palpable nodes, 50% may be reactive, but delay in treatment can affect progression. And so most of these people go, well, all these people should go on to have standard lymphadenectomy under normal circumstances, but it has a significant morbidity, as we've already alluded to. And here you can see someone who's got a necrosis on the side, on their wound. This is the question I've got. So in that data, of Kumar's data, they've taken all nodes in that sense, and I can't quite pick out the size of the nodes. It would have been great to really have that data, say what kind of size they were, or size criteria. I can't really see doing a laparoscopic or even a robotic lymph node dissection on something that looks like that. I'm not quite sure of anyone else's experience, but certainly I don't think that's possible. So the question is really, is it for those people who have small volume palpable nodes? And if we compare here, you can make the argument quite happily, if you compare just the UK data as opposed to the combined data there, that the complications are overall less. So hopefully, maybe this might come along, but I think it has to be for the right indication and in the right environment. Bear in mind, we're in a time of austerity as well. So basically, it's going to be patient group selection and the extent of the, and then we have to balance those risks and whether we take that combined data review or just the UK. So I think there needs to be more data, essentially. The other thing is this is innovative. And I think we should be commended on this from a UK point of view, and we should really encourage this. I think kind of putting it down and saying this is not something we should be doing is not necessarily a good thing. We think we should be moving forward. We are world leaders, I think, in penile cancer, certainly because of the centralisation. I suppose the other question is, where are the most gains to be made? And certainly, if you look at this, this is up-to-date data from VEILND. This is between 2000 and 2011, 203 patients. Half were treated with penile-preserving techniques. Lymph nodes, there weren't very many, but they're there. And those with N3 and N2 disease were treated with cisplatin, chemotherapy, or chemoradiotherapy. What's most stark about this is these people from N0 to M1, basically no one in M1 survives. No one really survives, or very few people survive in N3, and N2 doesn't look too great either. So this is an area that really needs to be focused on, and maybe some of those immune modulating drugs may be the answer to that. Here are some trials. These are the trials that we have done in the UK. I think that, again, is a good thing. We've got VINCAP, Penile TPF, Java P, all closed, by the way, no longer open. We've got MRI PET, which is the only active running trial that's using MRI scan to stage the groins, hopefully avoid having an operation. And then also IMPACT, which was opened in 2014, and is still not quite sure where we are with that. So what kind of else can we do to improve our research? What kind of things can we do to improve the lot for our penile cancer patients? Well, I think this is probably going to be the answer. I know this isn't UK-based, this is European-based, and where we stand in the future, who knows? But essentially, European reference networks, I think, are going to make a big difference to penile cancer. The idea is that they're going to have centers of expertise that people can contact with their patients and say, this is what's happening, and then they feed back and say, this is what we would do, or bring your patient over. There's be training parts of it, clinical guidelines, and research as well, collaboration. And this is the structure, just very briefly. So if you imagine you've got the European reference networks, our specifically one for urology will be the EuroGen, and that's split into 3 streams, and the rare urogenital tumor stream has penile cancer, testicular cancer, adrenal tumors, and abdominopelvic sarcoma. And that's not based in Europe, that's based here in the UK, that stream. That's run by Vijay Sangar, my colleague, and Christie's. So we've got a lot of work there. I think it's a real opportunity for all of us to really get on board with.
Ari, I'm just going to have to ask you if you can...
And I've finished. Don't worry. So overall, the incidence of penile cancer is increasing. Centralisation, I think, has benefited patients, at least in terms of survivorship, but whether this has impacted on survival is yet to be seen. VEILND seems to be a viable alternative in selected cases, but needs more data. And there are opportunities out there, I think, big opportunities to collaborate, but they need to be nurtured. Thank you very much.
Thank you very much, Ari, for that excellent talk. We probably have time for one very quick question. Yes, just over there.
Well, myself, Dogra, I am from Delhi, India. I appreciate the speaker deliberating on this topic, but we do see more of these cases, CA penis, and treatment and outcomes. My concern is only regarding the videoendoscopic lymph node dissection. We have seen the port site recurrence in a long-term follow-up. So I just wanted to highlight this point because you are considering this as the best option for treatment, but we have relied for the surface surgery as such. This may not be a very good option in view of the recurrence like we had seen, a port site recurrence following this procedure. Thank you very much.
Thank you very much. Ari, do you have anything to add?
No, I think that's that'd be interesting data out there. It's certainly not something that I'm seen reported or in large numbers in any case. So actually it'd be fantastic if actually you could report your data, because that would be, if you haven't already, and if you have, I'd love to see it. But that'd be, I think all of that will help and contribute towards VEILND and seeing which way this is the direction we should or should not be going.